fairly simple and streamlined protocols which allow laboratories to easily implement salivary testing for the virus. And the recent systematic review quite clearly showed that that salivary testing is the best alternative to nasopharyngeal swabs in terms of accuracy for detecting COVID-19. And again, this is very interesting and relevant finding because of the ease of obtaining a salivary sample. I think as time goes on, the emphasis will move more towards assessing immunity and immune response to the vaccination. The ability to detect an immune response to vaccines within saliva becomes more and more relevant. And in this particular study, the presence of antibodies with saliva was assessed. The other implication of this, and it's very, very interesting, I think, is the suggestion that saliva would pick up mucosal antibodies, and the presence of mucosal antibodies is very, very important in the context, again, of protection through an airborne route. So here we see that in this particular study, just recently published, that the control did not have much, as you would expect, antibody production. However, infected people, interestingly enough, had mostly a serum response, but not a salivary response, up until the point, and you'll note here, these two cases received a vaccine after 2 weeks, in the last 2 weeks, and you can see immediately upon receiving the vaccine that they mount an IgG and IgA response within saliva. So when they were infected, they did not have these salivary antibodies, but upon getting the vaccine, they did develop those. And then this was again confirmed upon vaccination with Pfizer and Moderna vaccines, where it was shown that after the second dose, all of both the Pfizer and Moderna recipients had mounted an IgG response, and most of them had also mounted an IgA response. So the issue around developing mucosal immunity is not certainly unequivocally answered by this particular study, but there is interesting data presented here, which brings up the issue of the role of salivary antibodies in future protection. So in conclusion, I just want to reinforce, I guess, the role of saliva as both a foe in the context of transmission. It is something that affected the dental profession severely, no doubt, all over the world, rightly or wrongly. I think we need to continue to research this area, and there's some very, very nice research coming out in this space about transmission within the dental setting, and we'll hear a lot of that today. But also appreciate the opportunities that saliva provides in the diagnostic space, and the ability to utilize this readily available biofluid for diagnosis generally, but in particular in the context of COVID-19. So with that, I finish my presentation and hand over back to the chairs. Thank you.
Thank you, Sasso, for this excellent presentation. And yes, we are really anxious to have the debate at the end, because there are many things, many relevant things that you have already covered in your presentation. So thank you very much again for the effort and for doing this at this very strange time of the day for you. And the second presentation is going to be the association between periodontitis and COVID-19 severity. And for that, we have Dr. Fali Tamimi. Dr. Fali Tamimi holds an academic appointments at McGill University in Montreal, Canada, and at the Qatar University in Doha, Qatar, where he currently serves as the Associate Dean of Academics of the College of Dental Medicine. His multidisciplinary and translational research covers various areas, including the fields of biomaterials, tissue regeneration, inflammation, and chronobiology. And Fale has published one book and more than 150 papers with over 3,000 citations. But we have invited him to participate in this webinar because he has just published a very relevant paper describing or evaluating the association between periodontitis and COVID-19 severity. So it's a pleasure to host you, Fale. Buenas tardes, buenos días para ti. How are you? And welcome to this webinar.
Yeah, thank you very much, David, and thank you for the idea to invite me, to give me the opportunity to share our project with you guys. So I'm trying to share my screen. I hope it works. Can you see my screen?
Yes, perfectly.
Okay, perfect. Yeah.
You just need to put the PowerPoint in. Yeah, perfect.
Okay, good. So yes. So as Dr. Sasso mentioned earlier, you already introduced the COVID-19, so I won't go into too much details about it. But there is something interesting about COVID-19, which is that even though most of the time it is asymptomatic and it causes a mild disease, in some patients it can cause a critical disease and even death. So the virus infects all the tissues in the body that have the angiotensin converting enzyme 2 receptor. It can affect multiple tissues, and in some patients something will go really bad. They will have a hyperinflammation phase, something that is commonly called the cytokine storm, in which these patients will have an over-inflammatory response in their body, and this could cause to really devastating complications and even death. So many studies were done to try to understand this better early on during the pandemic, and there is some things that popped out regarding the patients that end up having this severe form of COVID-19. One, for example, is the comorbidities. So many of these patients had hypertension, they had obesity, they were older, they had diabetes, they have cardiovascular problems. There were some biomarkers in the blood that were standing out, especially those related to inflammation, like ferritin, interleukin-6, C-reactive proteins. There are coagulation biomarkers that were also upregulated in the blood of these patients, like the D-dimer. And they also in the blood, they have in the blood analysis, you can see an increased activity of the neutrophils and a decreased activity of the lymphocytes. So this is very interesting because if you look at the periodontal disease, there is quite some overlap there. So periodontal disease is also associated with hypertension, with obesity, with age, diabetes, with cardiovascular diseases. Also in periodontal disease, you can have increased levels of ferritin in blood, of D-dimer, of interleukin-6, of C-reactive protein. And also the periodontal disease is associated with increased neutrophil activity and decreased lymphocyte activity. So there is some intriguing overlap between these two conditions. So it didn't take long for many people around the world to start publishing hypothesis papers that indeed there could be an association, some kind of relation between the periodontal disease and COVID-19. So many researchers, including Dr. Herrera, mentioned this in multiple very good articles. One study came out in November last year that actually came very close to demonstrate an association. So there was a study that came out from a group in the UK using the UK Biobank data. So this is data that on the periodontal status of patients that was done a few years ago using a nationwide survey. So this survey data of patients that they had in this data bank, and then they looked into these patients again after the COVID pandemic and see which ones of them were having complications or which ones were dying from COVID-19. And they saw an association between people that were reporting a few years ago that were reporting pain for bleeding gums and an increased risk of death from COVID-19 and increased risk of complications. So this is like the first evidence that indicating there might be something there. The problem is that this is a survey study on a survey that was done several years ago. I'm trying to link it with the COVID outcomes, it's not. It's a good starting point, but it's not very conclusive. So that's when we start to think about trying to maybe see if we can do something about it. So during the lockdown, like many of us, we were bored at home. We had a lot of time to think. So I called my dear friend, Dr. Mariano Sanz in Madrid, and I was just, we were discussing about this possible link between COVID and the periodontal disease. And at that point, I just had moved to Qatar in the Middle East. So Qatar is a very unique country. Because it has a unified national electronic healthcare record. So basically, the entire records of the country are digitalized of all medical conditions, and that includes dental records. So that's quite unique. So you have the entire data, you have a huge database on all the medical and dental records in the country in one single place. And on top of that, the healthcare system in Qatar is a public healthcare system that covers both dental and medical care. So that means that most of the people in Qatar, they get the dental care by the government, and also they get the medical care by the government. So we have a very comprehensive database that includes medical and dental care of the whole population of the country. So that's when we thought that maybe we could do something about it. Maybe we could use this database to demonstrate whether or not there is an association between COVID-19 complications and periodontitis and the periodontal disease. So what we decided to do is to do a case control study in which the patients that we were recruiting were basically the COVID positive patients, and the outcomes were either a mild disease in which the patients didn't have to go to the ICU or didn't have any complications, or complicated cases. So these are the ones that ended up in the ICU, intubated, or were deceased. And then our exposure was the periodontal disease. Our inclusion criteria were patients confirmed with a COVID-19 diagnosis between the beginning of the pandemic all the way till July 31st, 2020. We focus only on adult patients above 18 years old. And patients that were either discharged or deceased before our study end date, which was August 31st, 2020. Also, another important parameter for us was that all the patients, including the study, had to have an active dental record. That means that within 1 year before the onset of the pandemic, they had to have an active dental record in the system. Our exclusion were patients with no dental radiographs, because as I will explain in a few minutes, we rely heavily on the dental radiographs for our assessment of the patients' dental conditions, and patients that and patients under the age of 18, because they are unlikely to develop periodontal disease. So we identify in our database 1,076 patients with COVID-19 and with active dental records. So from these 1,076 patients, we excluded 65 because they were too young, and we excluded around 443 because they didn't have dental radiographs. So then we ended up having 568 patients that we could include for analysis. So for assessment of the periodontal disease, we used a method that relies on the panoramic radiographs. So the reason why we use this is because there is a lot of variability among dentists in Qatar on how they diagnose periodontitis and on how they register it on their record. So we thought that the best thing we could do to get really good quality data is to use the panoramic radiographs. So we use a method in which we look at only the posterior region of the OPGs, and we look at the side that has the worst condition, and we assess the ratio of between the exposed part of the root and the root that is in the bone. So this is a method that has been already established in previous studies, and we just adapted it to this. Has already been validated, and we adapted to our paper, to our work. So we basically classified patients into two categories: patients with stage 0 to stage 1 periodontal conditions. So these are the patients that had less than 15% of root exposure in the OPGs. And patients with a stage 2 to stage 4, which are patients that have more than 15% of exposed roots in their OPGs. We assess a whole bunch of confounding factors that we looked into. So this is the list. I want to go through all of them. But the most important were the smoking, diabetes, body mass index, age, gender, and many others. And also we were lucky that we had access to many of the blood work of these patients. So we could look into for example, analysis of the D-dimer, C-reactive protein, markers of diabetes, vitamin D, white blood cells, and lymphocytes. And we look into these biomarkers at 2 time points, early immediately after diagnosis, or before being discharged or deceased. For analysis, we use a heuristic regression analysis that was adjusted for age, sex, smoking, body mass index, diabetes, and comorbidities. Also, we did a sensitivity analysis stratifying data in subgroups. And for the laboratory values, we use the Mann-Whitney test. So now for the results, these are OPGs of disease patients. So these are, we had some patients in our cohort, like around 12 patients that fortunately passed away. And this just to give you a hint of how they looked. Okay, so the interesting thing is that some of them, even though they were relatively young, like female, 25, 24 years old, they passed away. But when you look at the OPG, you see that there is signs of periodontal disease. And in many of them, you could see signs of periodontal disease. So when we did our analysis, so this is basically the percentage of patients with periodontal disease, stage 2 or 4, or no, or mild periodontal disease. And this is among all the patients over here. So the majority of, all the COVID patients with complications. So you can see patients with complications, a vast majority have periodontal disease. Among patients that died, 92% of them had periodontal disease. Among patients with ICU admissions, 80% had periodontal disease. Among patients that needed assisted ventilation, 85% had periodontal disease. When you look at patients that had no complications, okay, the majority, like 57%, had no periodontal disease. So this is a clear sign that patients that are doing worse, they were much more likely to have periodontal disease than patients that didn't have complications. When we do our adjusted odds ratio analysis, so then the odds for having any complication was of 3.6. Okay, so patients with periodontal disease were 3.6 times more likely to have complications. They were 8.8 times more likely to die from the disease, 3.5 times more likely to go into the ICU, and 4.5 times more likely to need assisted ventilations. And these associations were statistically significant after adjustment for age, sex, diabetes, smoking behavior, and the list of comorbidities that I showed earlier. When we look at the blood parameters in these patients, so as expected, deceased patients, ICU patients, and patients that end up in ventilation, they had higher levels in the blood of C-reactive protein, of white blood cells, and of D-dimer, and they have lower levels of lymphocytes. So this is kind of expected. This is what it's already available in the literature in many other studies. So this is just to corroborate what is already there. What was new was this thing over here, which is those markers in the patients that with periodontal disease. So what we saw was that indeed patients with periodontal disease had higher levels of C-reactive protein in the blood at admission and before being discharged. Also, before being discharged, they also had higher levels of white blood cells, and they had also like increased HbA1c in blood before being discharged. So there is a few hypotheses that why this is happening, why there is this association between COVID-19 and periodontal disease. One possible explanation, it's a direct link between the bacteria in the oral cavity and the lungs. So there is some hypothesis there that people have found periodontal bacteria in the lungs, so maybe this bacteria could be making things worse. And then there is another hypothesis that I think I'm actually more in favor of this one, which is actually that the fact that the periodontal disease is causing some priming of the immune system. The chronic inflammation in the body is priming the immune system, so that when you get COVID-19, you're at a worse starting point, okay, and you're more likely to go into more complications. So in conclusions, the periodontal disease was associated with a high risk of ICU admissions, with the need of assisted ventilations and death of COVID-19 patients. And in COVID-19 patients with periodontitis was associated with increased blood levels of biomarkers linked to worse disease outcomes. So I would like to thank my team in Qatar, especially Dr. Nadia Marouf, that she did a lot of work of this study, and also my collaborators in Spain and in Canada. Thank you.
Thank you, Fale, for this excellent and enlightening presentation. So I'm sure the audience have a lot of burdening questions, but we will take them at the end of the session. So now I would like to welcome our next speaker, Dr. Purnima Kumar, who is a professor of periodontology at the Ohio State University. In addition to her clinical practice, Purnima maintains very active research in oral microbial ecology and microbial pathogenesis. Purnima also has been a very passionate leader in our field, has served on various IADR committees and ADI councils, including Task Force for Women in Periodontics. She is currently Associate Editor of Journal of Periodontology and also the incoming Vice President of Periodontal Research Group of the AADR. Today, she is going to explain to us the role of aerosols in the transmission of SARS-CoV-2 in dental practice and maybe in periodontal practice, and answer questions related to methods of preventing virus transmission. With that, I would like to hand over the word to Purnima. Thank you, Purnima, for joining us today.
Thank you very much for organizing this very timely and important seminar, and congratulations to all the speakers for the great talk that you've given us. I'd like to take the 15 minutes I've been allotted to talk about aerosols and the spread of microorganisms through aerosol generating dental procedures. Please, I want to make it very clear, I'm not talking about dental aerosols, which can happen at any time, but truly about procedures, dental procedures that generate aerosols. On March 16th, 2020, we had a guideline to close dental offices for anything but emergency treatment. And when we reopened on May 4th, all of us who are still now in clinics do remember what we had to go through with the N95 masks, increased requirements for air filtration, and aerosol mitigation devices. So this guidance was based on evidence from very early on, as well as current evidence. I mean, this is a very, very striking study that was published in JADA in 1994, where microorganisms were collected from different sites on the operator, the patient, and the assistant, and at different sites within the dental operatory, cultured to identify what these species were, and counted. The colonies were counted, and this was the result. So there were 5 instances, and there was evidence that dental aerosols carry microorganisms. Evidence from other researchers showed us that aerosols can spread up to 11 meters and persist anything from 30 minutes to 2 hours, depending on the study that you're looking at. However, when you start asking, what is it? What are the types of bacteria that are present in these dental aerosols? We found that there are very few studies that actually catalog these bacteria and characterize them. The British Dental Journal 2000 article showed us that a 15-minute exposure to aerosol leads to an inhalation of about 0.014 microliters to 0.12 microliters of aerosolized bacteria. And the few studies that we did have until now showed us that most of the bacteria in dental aerosols were environmental in origin. Staph aureus, which is skin and environment, E. coli, spore-forming bacteria, fungi, and certain beta hemolytic streptococci, which were ascribed to oral sources. There was no study that ever identified viruses in dental aerosols or even looked for viruses in dental aerosols. What was striking as we reviewed these studies was that the dilution factor when dental aerosols, unlike medical aerosols, use some kind of an irrigant or a coolant fluid, most dental procedures. And this coolant the rates of flow of this coolant is different based on the type of instrumentation and the type of procedure that you're doing. And even assuming a very minimal water coolant or irrigant to saliva ratio, there is a 10 to 100-fold dilution of saliva before it becomes an aerosol. And in the presence of high volume intraoral evacuation and with pre-procedural mouthwash, there was little evidence about what exactly these microorganisms were. And so today I'm going to summarize 3 studies that we did in relation to this. The first question was, and I think this is prescient right now because most of us with vaccinations and history of COVID exposure and COVID disease itself are non-symptomatic. We are not presently symptomatic. We could be post-symptomatic or pre-symptomatic. And many of the patients in our practice are most likely going to fall into this cohort. And so it was important for us to analyze, assess the prevalence of SARS-CoV-2 in non-symptomatic patients. And this is a group that includes pre-symptomatic, post-symptomatic, and currently asymptomatic patients. The second question, which of course is important, is what is the source of these microorganisms in aerosols generated during dental procedures? And the third study that we did was to understand if mouthwashes could indeed reduce SARS-CoV-2 in saliva. So the first study, again, I will tell you, all of these are very small sample sizes. They were done during the height of the pandemic. And so by necessity, having unvaccinated examiners and clinicians and situations where things were under tight control and under restrictions, this was what we were able to achieve. So we had 2,201 patients who we screened using the ADA questionnaire for COVID. Those who were screened positive, we documented them and asked them if, these are patients who were presenting to clinical practice, so they were not active COVID infection patients. We had some of them, 15 of them had recovered from, gave us a positive history of COVID SARS-CoV-2 infection and recovery from infection. They were at least 2 weeks post-symptomatic, and so we grouped them. Several of them were screened negative based on the ADA questionnaire, and then we inducted them into the non-symptomatic group and followed these people up with a repeat questionnaire at 48 and at 72 hours. Those who showed COVID symptoms at 48 or 72 hours, we grouped them into the pre-symptomatic group, and then the rest of them, we grouped them into the asymptomatic group, fully acknowledging that the asymptomatic group could still be carrying some pre-symptomatic individuals. They just hadn't been caught within the 72-hour window. But at that time, the guidance was to make these follow-ups at 48 and 72 hours, so that's what we did. We collected samples from all of them when they presented to us. So this was a single one cross-section study. We collected samples when they presented and quantified SARS-CoV-2 using the reverse transcriptase quantitative PCR that was advocated at that time. And this is a demographic of our study population for the study. And as you can see, there wasn't much of a difference between the groups in terms of ethnicity, age, or gender. However, sorry, I need to go back here. However, what we found was that these groups did differ significantly in detection frequency and in the viral load in saliva. So this is salivary carriage. And so the detection frequency, we found that patients who are asymptomatic or pre-symptomatic either 23 to 28% of them, we could identify SARS-CoV-2. And when we did identify them, the viral load in 1 milliliter of saliva was extremely low, was about 234 copy numbers or about 198 copy numbers. So the viral load was extremely low. And just for comparison, we added a symptomatic COVID group, a COVID positive group. This was done in collaboration with the Wexner Medical Center here at Ohio State University, the COVID unit. And so we went into the COVID unit and collected samples from 40 subjects. And we found that 39 out of our 40 subjects we could detect the SARS-CoV-2 virus, and the levels, as you can see, were extremely high. But the interesting thing was, when this was analyzed statistically, we found that the detection frequency differed significantly between asymptomatic, pre-symptomatic, and the post-symptomatic and symptomatic group. There was no difference in detection frequency. This was not statistically significant between the post-symptomatic and the symptomatic group. Of course, the low numbers might contribute to the lack of significance, but this was interesting to note. Similarly, what we found was the viral load was significantly different between the asymptomatic and pre-symptomatic groups and this other group. So the differences were only between when people were asymptomatic or pre-symptomatic. Those who had COVID or who were currently experiencing COVID were not significantly different from each other in this sample size. So then we went on to ask what the source of microorganisms in aerosols that are generated during aerosol generating dental procedures. And to do this, we tested 3 instruments: an ultrasonic scaler, dental implants, and restorative procedures using a high-speed turbine. So we collected samples from the patient's chest. This, if you can see, is a dental chair, the operator, the assistant, and a source, the cabinet, the dental cabinetry that is, the operator cabinetry that's here about 6 feet away from the patient. So these were the samples that we collected. But all of us were wearing face shields. All of us were wearing N95 masks. And so it was easy to collect samples from these disposable face shields. From the patient's chest, we collected from a part on the bib. And again, this is only 28 subjects, a very, very, very small sample size. But we wanted to understand truly where are these bacteria coming from. And so this was the study designed for this study. And we collected these samples and we did 16S sequencing. Now this has become almost it's commoditized, so everybody does 16S sequencing. But what we did that's slightly different from most conventional 16S sequencing was in the bioinformatics approach. We, instead of assigning taxonomy, that is names, bacterial names, species names to these amplicons, we looked at the genetic differences, at the difference in the gene sequences of these different sequences. And based on these sequence variations, we collected what are known as amplicon sequence variants. So this is almost identifying bacteria to the strain level rather than stopping at species and trying to collapse all of these millions of sequences into 500 or 400 bacteria. This gives us idea about the different strains of bacteria that can be present within the same environment. This is pioneered by Ben Callahan and his group, and they have had extreme success in using this to longitudinally trace mother-to-child transmission and other things. And remember the keyboard study, identifying who you are based on the keyboard bacteria that are present on your keyboard. So this was done using the amplicon sequence variants. We also examined SARS in all of these environments, the operator aerosol, the assistant's aerosol, the patient's chest, and the environment. We checked for SARS-CoV-2. And we used a bioinformatic algorithm known as source tracker. So what source tracker does is it assigns something, anything. You can assign a source and you can assign a sink, and you can test the hypothesis which of the sources, 2 or 3 sources, contribute most to the bacteria that are present in the sink, that is the reservoir, the recipient, right? So this is the source. We designated 2 sources. We designated the irrigants that are present in the handpiece, in the ultrasonic, and in the implant. as one potential source. The second potential source was saliva from the patient. And so for each patient, we asked, is it from the irrigant or is it from the saliva? And the recipient, the sink, was the operator's face shield, the assistant's face shield, the patient's bib, or the countertop. So we're asking which of these two contribute the most microbiota to what the aerosol that is present on the operator. So this is known as source tracker. And using this and amplicon sequence variance as the variable, input variable for source tracker, this is what we found. So this is the proportion of contribution. So 1 is 100%, 100% contribution is 1, 0 is no contribution. The black bars are irrigants. These hatched bars here are saliva, and the gray bars are unknown sources, which means that they could not be attributed either to saliva or to the irrigant. It doesn't truly mean unknown. It simply means that it doesn't come from these two sources that were given as sources. Each of these numbers here represents a patient. You'll see some notes, some asterisks here. These are patients who declined to use a pre-operative mouthwash. So the protocol when we were doing the study was to use a 1-minute hydrogen peroxide mouthwash pre-operatively, within 10 minutes pre-operatively. So this was the protocol at that, the guidance at that time was to use a 1% hydrogen peroxide mouthwash for 1 minute. And these 5 patients declined to use it or did not use it for various reasons. And so they are indicated by an asterisk. So each of this is a subject. As you will note, there are 28 subjects in the study. 10 of them underwent implant surgery. 15 of them underwent ultrasonic treatment, and 3 were in restorative. The standard error of mean is indicated on all of these things. So fundamentally, what you can see is that the irrigant appears to be a large source of a large fraction of the bacteria that are present in aerosols depositing on the assistant. Saliva is present in a certain number of cases, but when you look at which patient contributes saliva to the aerosol, salivary bacteria to the aerosol, many of them are ones who have not used mouthwash. So that you will notice will be a repetitive theme as we go through. Here's the operator. Again, the large bars are coming from irrigant. There are also lots of unknown, which are not you can't designate it to either the saliva or to the irrigant. They are from other sources. And saliva is a source in number 10, in subject number 22, in subject number 26, to a small degree in subject number 13. So in some of these subjects, yes, there are salivary bacteria, but they seem to be more present or more frequent contributors and more significant contributors to aerosol microbiota when the patient does not use a mouth rinse. Again, I want to pause for a second and tell you that at this point in time when this study was done, we were using intraoral high volume evacuators, HVEs, for every single patient, every procedure. So this was done under conditions of high volume evacuation and pre-procedural mouth rinse of hydrogen peroxide 1% for a minute. In the environment, again, you can see that saliva is a giant source for patient number 22, for patient number 26, but hardly any of them. It almost always seems to be the irrigant. Now, when we come to the patient, you will see that the saliva starts showing up more frequently and more significantly as a source. Again, this is a more significant source when a patient does not use mouth rinse, but it's also a significant source when it's not. I don't want to say it's a significant source. It is present. It can be identified as a source in other situations as well, but these were most often identified only on the patient. So when salivary microorganisms are present, they seem to condense more often on the patient's chest than on the operator's face shield, the assistant's face shield, or an environment 6 to 8 feet away. When we looked at SARS-CoV-2, there were several of our patients who did have SARS-CoV-2 present. So if you look at it, I can't remember the exact number, but a significant number of these patients did carry SARS-CoV-2. They were part of the asymptomatic study that I showed you before. So many of these people did carry SARS-CoV-2, but SARS-CoV-2 was not identified in any of the aerosol samples. We were not able to identify SARS-CoV-2 in any of the aerosol samples. And if you look at the viral load, the converted viral loads, you will see the copy numbers. You will see that the copy numbers are very, very low. The highest copy number we found was a 912, which is much lower than the threshold of infectivity that has been set up by other studies in the literature. The last study we did was, as I said, in the COVID unit of the Wexner Medical Center. And for this study, we recruited 41 COVID patients. We collected baseline saliva samples from them. And then we randomized them to one of four groups: saline, chlorhexidine, povidone iodine, or hydrogen peroxide. The way they used this was they used 15 mils for 30 seconds, spit it out, rinsed again with 15 minutes for second 30 seconds, spit it out. So we pooled the expectorant, collected the expectorated mouthwash as sample 2. So this is baseline saliva was sample 1, expectorant saliva was sample 2. And then we collected saliva 15 minutes post-rinsing and 45 minutes post-rinsing and quantified SARS-CoV-2. And this again is, as you're looking at it, this is the black bars are the 15 minutes to baseline reduction. So what you're looking at is mean reduction, right? This is a 100% reduction. This is a 0% reduction. And this is reduction compared to baseline. So we're comparing baseline to 15 minutes or baseline to 45 minutes. So this is a mean reduction, and this is a mean reduction at 45 minutes. So baseline to 15 minutes and baseline to 45 minute median reduction. I'm sorry, not mean. Median reduction is what you're looking at. And there was no statistically significant difference between the mouthwashes. The four mouthwashes, there was no statistically significant difference between the mouthwashes, but all mouthwashes were able to reduce salivary microbiota between 60 to 80% at 15 minutes and at 45 minutes. Not salivary microbiota, but salivary SARS-CoV-2. And so to summarize, SARS-CoV-2, the prevalence salivary carriage of SARS-CoV-2 is significant. It's 25% of asymptomatic, 60% of post-symptomatic, and 28% of pre-symptomatic individuals do carry SARS-CoV-2 in their saliva. In post-symptomatic individuals, the levels are higher, at least 1 or 2-fold magnitude higher than in asymptomatic and pre-symptomatic individuals. Mouthwashes in acute COVID patients does reduce viral load, 61 to 89% at 50 minutes and 70 to 97% at 45 minutes. And in asymptomatic patients, under conditions of high volume evacuation and pre-procedural mouthwash, the microbiota that are present in dental aerosols mostly appears to come from the irrigant fluid and very little from saliva. And when it is coming from saliva, it is mostly deposited on the patient's chest. On behalf of the IADR and the PRG, I'd like to thank you for your attention.
Thank you, Purnima. Thank you, Dr. Kumar. Thank you for sharing this very relevant information, which is very positive for us, and also it explains why are you presenting from the dental clinic, because it looks like a very safe place. And I think the next presentation is going to deal also with that. So it's we're going to be presented by Dr. Ian Chappell. The title of the presentation is "Are Oral Health Professionals More Likely to be Exposed to COVID-19?" And Professor Ian Chappell is Professor of Periodontology and the Director of Research for the Institute of Clinical Science at the University of Birmingham, England. His clinical interests lie in periodontal medicines and surgery. He has served as editor of multiple journals and is the current associate editor of Periodontology 2000. He has written numerous textbooks and book chapters and published over 200 peer-reviewed manuscripts. He has many leadership positions, especially at the IDR. He has been the IDR Periodontal Research Group President, Group Chair, Counselor, and in 2018, he was awarded as the IDR Distinguished Scientist Award in Research in Periodontal Diseases. So please Professor Chappell, please, Ian, it's a pleasure to have you here.
Thank you, David. Can I just check you can see my full screen and not presentation mode?
It's presentation mode.
Okay, let me just change it over then. Not that I have any notes. That should hopefully be the full screen, yeah?
But it is the size of the screen. We are not able to see everything. It's just the center of the images. So you are sharing just the middle of your screen.
Okay,
so you
let me come back again. Let me stop sharing and let me open it on a different window, maybe. See if we can get it to do it this time.
But we could already see the important thing, which was Professor Jan Benstrom.
Yes. So let's try again. How is that?
Now it's perfect.
Great, excellent. Well, thank you, David. And I wanted to start with a recognition of Jan Benstrom, who really was not just a brilliant scientist, but also a wonderful human being and a great gentleman. So my talk, like the others, is dedicated to his memory. So I've been asked to answer the question, are oral health professionals more likely to be exposed to COVID-19? And by way of background, and we heard some of this from Sasso and also from Fale, basically, in order for entry of the SARS-CoV-2 virus into cells, you need those cells to be expressing the ACE2 receptor, along with various cofactors like TMPRSS2 and furin. And they are in fact expressed in the gingivae and the salivary glands and the tongue. And cells from the sulcular epithelium also express all three of these molecules. And therefore, one could argue that the gingival sulcus is a potential target for infection. So the other things that we know, and some of these papers have been referenced already, is that SARS-CoV-2 infection has been confirmed in salivary glands and oral mucosa, and indeed replication of the virus has been shown in those tissues. In post-mortem studies, the virus has been shown within periodontal tissues, and saliva RNA levels peak at about 7 days, and as Panema showed, somewhere between 10 to the 4 and 10 to the 8 per mil, which is about 1,000 million is really quite a high viral load, can be present in saliva. SARS-CoV-2 is also detected in dental plaque. This is a very recent paper by Sabrina Gomez and colleagues, and then also, as you would expect, within crevicular fluid. So I guess it goes without saying, given that data, that dental care professionals would be thought to be at high risk of occupational exposure, and also because they work within a meter of the air and digestive tract. But robust data from seroepidemiological studies is still currently lacking. So the aims of our study were to determine the seroprevalence of antibodies to SARS-CoV-2 to the spike glycoprotein, and this was prior to the implementation of the enhanced personal protective equipment, PPE, that Panema referred to. We then followed up seroprevalence in the same population following the introduction of enhanced PPE. And we were also able to analyze in February this year early vaccination responses to the first of the Pfizer-BioNTech vaccine shots. So the study commenced in June 2020 in Birmingham Dental Hospital, where I'm based in the UK. Our professional volunteers were dentists, dental nurses, hygienists, therapists, and receptionists from across a Midlands population of 6 million. So it was a region-wide study, and we shared our data with the Department of Health and Social Care to help them plan services. And we essentially, at baseline, took samples from 1,507 DCPs, and we took both blood for serology and saliva for salivology. The assay that we used is one developed in Birmingham, and it's an assay that measures IgG, A, and M to the spike protein. So it's specifically designed for seroepi studies, and it provides a very high level of sensitivity and specificity, over 98%, for that purpose. There are limitations, which I'll come on to later. Seropositive volunteers were then retested 3 months later in September 2020, And then we invited all volunteers back in February of this year. That was 6 months following baseline, and we retested just under 1,000. So the study flow chart is here. You can see that of the 1,700 that agreed to participate, we bled 1,531. We eliminated some because they actually didn't work in dentistry. And then we essentially had 246 who were seropositive. We then reviewed those seropositive individuals, and 217 of the 246 came back for rebleeding at 3 months. And then we invited the whole cohort back at 6 months. And interestingly, the outcome was about 50-50 seropositive and seronegative, because at this time in February of 2021, we had a significant spin out or rollout of the vaccination program. So the seropositives were partly due to natural infection, but also partly due to vaccination. So results-wise, this is a busy slide. I'm just going to highlight the key findings here. There was a significantly greater seropositivity in those of Black ethnicity compared to Asian or white ethnicity. Significantly higher seropositivity in those that had a high index of multiple deprivation. And interestingly, significantly lower seroprevalence in current smokers relative to former or non-smokers. And we'll come back to that. In terms of baseline results, then 16% of dental care professionals tested positive for the IgG and M antibodies to the spike protein. So of those 16% that were seropositive, it was evenly balanced across dental surgeons, dental nurses, hygienists and therapists. And the background population rate was 6%. So you can see almost a 3-fold increased exposure or increased seropositivity to the background population in the Midlands from the patient-facing dental professionals, whereas the dental receptionists who were not patient-facing were down at background population levels of 6%. And you can see here the odds ratios for Black, Asian, minority dental professionals compared to white. And you can see here the reduced odds ratio at 0.3 for current smokers for seropositivity. In terms of symptoms, those with no symptoms, there were 71% had no symptoms, and 9% of those were actually seropositive. So asymptomatic exposures, I suppose, is how we would categorize them. And of the 29% who had symptoms, then 34 of those tested positive and 65% tested negative. Of the 71% with symptoms, for those who tested positive, 44% had a fever. And in terms of ageusia or anosmia, loss of taste or smell, you can see this was by far the best predictor of seropositivity, with 66% seropositive. So if we look at the 3-month post-baseline data, this shows you the IgG A&M ratios for our baseline seropositive individuals in June against the cutoff here, and again in September. And there's a general decline in seropositivity, but it's not particularly dramatic. Most seem to retain antibody levels above the threshold of detection. We also looked to see if those antibodies were neutralizing antibodies, and the majority were. What this shows you is percentage infection of a cell line. Essentially, the black bars are people in June, and then the same individuals in September are in the pale blue here. And in the vast majority, there's no pale blue appearing at all. So we're getting neutralizing antibodies, with the exception of 1 or 2 individuals only here. We then wanted to look at the IgG and the IgA levels. So we reran assays for the entire group of seropositive individuals. And so you can see here in the middle panel IgG, and in the right-hand panel IgA. And this is at baseline in red, 3 months in blue, and then 6 months in gray. And the 6 months, I would point out, is between 9 and 12 months following infection, at 6 months following our baseline examination. And you can see a 72% retention rate of antibodies of IgG isotype, whereas the IgA isotypes were relatively low in prevalence. So antibodies post-natural infection were retained at 6 months following baseline by 71%. Anti-spike IgG and IgA were detectable in 73% and 35% of volunteers respectively at baseline. That was then 67% and 21% at 3 months follow-up, and 72% for IgG and 28% for IgA at 6 months follow-up. And of the 944 that we rebled at 6 months, there were 94 PCR positive cases reported, which gives an overall infection risk of 8.4%. And that was made up of seronegative individuals at baseline at 9.7% and seropositive baseline individuals at 2.9%. So basically a 75% reduced risk of those who had antibodies at baseline from natural infection at 6 months follow-up. And I think very importantly, symptomatic infections only occurred in the absence of specific baseline IgG responses. So from our 944 attendees at 6-month follow-up, seroconversion had arisen in approximately 50%, either through natural infection or vaccination. Of the 329 re-attendees who were seronegative at baseline and who had not been vaccinated, seroconversion had arisen in 19.7%, which seems quite high, but we had the UK or Kent variant at the time of these. UK dentistry reopened on the 8th of June in 2020 under the new Public Health England guidance and the enhanced protection, the enhanced PPE. And the seroprevalence in the Midlands increased by 12% between June and January of 2021. Whereas the seroprevalence in our dental care professionals increased by 11.7% in the same period, so pretty similar. So these data imply that the enhanced personal protective equipment did appear to mitigate the additional risk of infection to background population levels effectively. When we look at the kinetics of the antibody response to the Pfizer-BioNTech vaccine, this is in just under 500 that were vaccinated, and these blue dots are people who were seronegative at baseline. And you can see that in those that were seronegative at baseline, in order for us to get 100% over the threshold of detection, it took almost a month. You can see we start to get seroconversion at around about 10 to 12 days. But where we look at those who were positive at baseline, seropositive through natural infection, you can see firstly very, very high mean levels of antibodies when vaccinated with a single vaccine. And also it only takes around 3 weeks for 100% to get above that threshold. So 97.7% of seronegative individuals developed an antibody response following vaccination at 12 days, which is pretty impressive. The vaccination, however, for those who had previously been naturally exposed to SARS-CoV-2 led to a much more rapid and a more robust antibody response, which was really indicating the boosting of immunological memory. We were able also to determine against the new WHO standard for SARS-CoV-2 immunoglobulin levels, we were able to determine against that standard a threshold of 147.6 international units per mil of IgG that conferred protection from infection at 6 months. And none of the cohort where those IgGs were above that threshold at baseline tested positive for COVID-19 in the following 6 months. So to conclude, unvaccinated dental care professionals who are patient-facing do appear to be at increased risk of SARS-CoV-2 in the absence of appropriate enhanced personal protective equipment. Whereas once that's introduced, the levels of exposure appear to drop to background population levels. DCPs of Black ethnicity and those with increased deprivation indices had increased odds of seropositivity, and current smoking led to significantly reduced odds of seropositivity. Natural infection or exposure to SARS-CoV-2 conferred a 75% risk reduction of reinfection at 6 months, and the IgG A and M responses in those that were seropositive at baseline remained in the majority, 71% of those individuals at 6 months following baseline, which is 9 months following infection. And IgG levels of around about 150 international units per mil in serum appear to confer a 6-month protection using that WHO standard. So I need to acknowledge Thomas Dietrich and Adrian Shields, my co-workers, and once more recognize the tremendous work of Jan Wenstrom, to who this presentation is dedicated. And thank you very much for your attention.
Thank you, Professor Chappell. Thank you, Ian. It's been a fantastic presentation, especially because it's a tribute to Professor Wenstrom. So I'm now inviting all our speakers to activate their videos so we can start this question and answer portion of the webinar. We will not be able to tackle all the questions, there are many, so we are really thankful for the attendees, first for attending, and secondly for their active participation. And I'm sure that Professor Bogdansi Nagy, she wants maybe to start with the first question of this session.
Thanks, David. Indeed, I think we have approximately 15 minutes, so we could maybe use this time. So the first question will go to Sasso. Sasso, the question is about the virus viability in saliva. Is there a way to point out if the virus is viable in saliva? Would you be able to elaborate on this?
There's been quite a number of studies that have shown that the virus is viable in saliva as well as other biofluids. I think it definitely survives in aerosols for a number of hours and on hard surfaces for longer than that. I think in terms of demonstrating that, aside from simply testing for its presence, is to use it to reinfect the epithelial cells. So there's some assays that can be used to demonstrate that.
Thanks, Sasso.
The next question is for Professor Tamimi. There are different participants who has wondered or has described maybe some of the limitations of the study, which on one hand, and I would like you to elaborate on that and give us your impression. On one hand is the use of radiographs to identify disease when your hypothesis was more connected with inflammation rather than with bone loss. And on the other hand, the confounders. So if in the study that you have presented, the risk of severe COVID-19 was associated with periodontitis, but some of the participants were wondering if that was the case also with diabetes, chronic heart disease, hypertension, age, etc. So I wonder how you were able to consider or to put into the conclusions these limitations of these problems that of course all of these studies will suffer.
Yeah. So that's completely true. So our study has limitations. Like a main issue when you are conducting this, trying to assess this link between periodontal disease and COVID-19 is that it's very difficult to bring a patient that is in the ICU to do periodontal probing. So we have to work with that limitation. So the second best thing would have been to have high quality periodontal probing data on the patients that went to the ICU. So unfortunately, in our setup, we didn't have access to that. I think probably in the future, as research in this field gets better, maybe we might have cohorts of patients with good high quality periodontal charts that we could do that. So given those limitations, the next best thing that we could work on was the radiographs. Of course, the radiographs doesn't show you if the disease is active or not. It's just showing the bone loss, but that's the closest we could get to have an objective assessment of the periodontal disease. Having said that, there is actual studies that have validated this approach in the past. So there is a good correlation between what you see in the radiograph and what is actually happening. Regarding the second question, which is a very important one, is the issue of the comorbidities. So the answer is yes. There is, of course, there is the patients that were sicker, they had these comorbidities, and the patients that had periodontal disease also had these comorbidities. So the issue is whether periodontal disease is and the COVID-19 are both affected by the comorbidities, or whether the periodontal disease maybe could be affecting both the COVID and the comorbidities. We cannot really tell. So what we say is that there is an association there, but we cannot say that one is causing the other. Having said that, what we did in our analysis to address the issue of the comorbidities was to adjust for them. So in that analysis, when we do the logistic regression, we adjusted for all these comorbidities like sex, hypertension, diabetes, age, and so on and so forth. And that's one way of doing it. But in order to make sure that it's we're not missing anything, we did also another type of analysis, which is stratified analysis. So basically, we looked into subgroups of patients. So what about the diabetic patients on their own compared to non-diabetic patients? Are they different? Or non-smokers versus smokers? Do they have a different risk of complications related to the periodontal disease? So when we did this stratified analysis, then we saw something interesting. So for example, non-smokers with periodontal disease were actually associated with COVID complications, and young patients with periodontal disease were associated with complications, regardless after adjustment for other comorbidities. So that's the two type of analysis that we did to manage the confounders. Hopefully in the future, when studies with larger cohorts and larger sample size, we could get into more details and more sophisticated analysis.
Thank you, Fale. And now I guess that again, Nagi, maybe you want to.
I think we got a few questions while we were discussing. So the next question will go to Dr. Kumar. I will try to combine a few questions leading to the same way. So that the question were, how were the microbial samples collected? Was this by swabs of surfaces or by air sampling? How many minutes after the mount rinse were the samples collected? The question was it this trajectory over time?
Thank you. So the samples were collected from the operator and the assistant. The face shields, these are disposable face shields. So the face shields were collected and then rinsed to collect the samples. For the patient and the environment, these were passive condensation. So there were petri dishes that were set on the patient's chest and in the environment. So that is how the samples were collected. The second question was mouthwash. The samples were collected immediately, so 15 minutes after using the mouthwash and 45 minutes after using the mouthwash. So is that?
Yeah, I think we have one more question following up that the question is about, is there no difference of mouthwashes to saline? Are they saying, did we misunderstand?
So that's a very interesting question. Yes, we did not find any difference between mouthwash and saline. So then, like, the person who asked the question, we wondered if this is, some kind of an artifact, and we actually sequenced the mouthwash to see how much we collected. So there was no, the expectorated mouthwash, right? After the patients rinse with the mouthwash and they spit it out, within the mouthwash, the salivary, the COVID level, the SARS-CoV-2 levels were really, really high. So again, neither in the mouthwash nor in the patient's saliva after the mouthwash we could find any difference between the two, making us think that this removal is more mechanical rather than this reduction being some kind of a chemical or mechanical process. So it seems to be just a mechanical removal. But the good news is it persists for 45 minutes after a single mouth rinse. So that was the encouraging news.
Thanks, Purnima.
Thank you, Purnima. And now back to the UK. Dr. Chappell, we have a number of questions for you related with vaccination protocols, and also with the smokers. So I don't know what you prefer to start with. I mean, some of the attendees were surprised about the differences in the seropositive rate and also in the response of in smokers, and they were wondering what could be the biological explanation, what would be the biological mechanisms involved in that.
Yeah, so it's very interesting. I've been doing some work with a radiologist and anatomist, Graham Lloyd-Jones. We put a sort of a hypothesis out there that SARS-CoV-2 is not predominantly transmitted into the lungs through the airways at all, actually, because the airways are clear. And if you look at where the inflammation is, it's actually basal and lateral in the lungs. And if you then look at CT scans with contrast, the inflammation's in the blood vessels. So we sort of put it out there and opened it up to say, look, guys, this could be a bloodborne virus, and the spike protein has since been shown in the blood. And if it's a bloodborne virus, then how's it getting into blood? And where's it coming from? And of course, the mouth and the nose are the most likely sources. And I think the gingival and periodontal tissues, bearing in mind it's in subgingival plaque, it's replicating in the mouth. You've got such high levels in saliva. And of course, when you think about it, and this is purely a hypothesis at the moment, smokers do suffer they experience vasoconstriction. So a reduction in blood supply to the periodontal tissues is very, very well reported in smokers. So maybe that's one potential explanation. Another potential explanation is smokers have thick mucus, and they produce thick mucus. And we're not the only ones to have shown this for current smokers, by the way. This is not an isolated finding. It is well recognized. And there's also some potential evidence that nicotine may also bind to the ACE2 receptor. I'm not sure how robust that data is, but you could also have a competitive inhibition taking place. So there's three theories. Regarding the vaccine, yeah, I mean, I don't know. It's a really good question, isn't it? You've effectively had your first vaccination when you develop the natural infection. And when you look at the rate and the robustness of the immune memory response, maybe you only need one shot and not two if you've already been exposed. But as far as I'm aware, those studies haven't been run, and they would need to be run to demonstrate that for it to become a safe, accepted protocol, I think.
You were actually answering a little bit the question about the different protocols of vaccination, but maybe what is and is something that Sasso also mentioned is about the presence of immunoglobulin in saliva and in the mouth. How do you see that with the current vaccination protocols that we have today?
Yeah, so we're literally analysing the saliva samples at the moment. You'll appreciate 1,500 blood samples is a lot to analyse, and then to do the isotypes as well. So we're in the middle of looking at what I would say is that we know from other studies that the mucosal immune response is different to the systemic immune response. So it's going to be really interesting to see if the IgA levels in saliva are higher than we found in blood, because they weren't very high in blood, and they certainly didn't hang around as long as you saw as the IgG did. The IgG is the predominant isotype that is important in protecting, if you like, against SARS-CoV-2 rather than the IgA. But so I'm sorry, I can't answer that question yet, but once we've analysed all the spit, I'm hopeful that we can give you an idea on that one.
Okay, thank you, Ian. We are running out of time, so I would like each of the presenter in the order in which they have presented to give their final message, the take-home message. So, because I think there are many relevant and interesting things which has been said today, and I would like the audience, before in Australia they go to bed, or in the United States they start working, to really get a clear message for. So I would like Professor Ivanovsky to start first, and then we allowed him to go to bed.
I think my take-home message would be that saliva has significant potential as a diagnostic tool, but also a monitoring tool for immunity. And I think the issue of mucosal immunity is one that requires further work, and hopefully Ian's research will answer some of those questions.
Thank you, Saso. It's been a privilege to have you in this webinar. Thank you very much for your
Absolutely.
effort.
It's been a pleasure to be part of it. Thank you.
Please, Dr. Tamimi, you need to switch on your microphone.
Yeah, so the message is that during the pandemic, many people try to take many precautions to try to avoid getting sick. Like some people, we wear masks, we try to social distance. Some people also take some precautions to improve their health, improve their diets and exercise and getting the vaccine. But maybe flossing and brushing your teeth could also be part of that, of the list of things to do.
Thank you. That's a very positive message. And I now ask Purnima, Dr. Kumar, what would be your final message?
Final message. Well, there's a lot of SARS. There are a lot of people, folks, potential patients who do carry SARS-CoV-2 in their saliva. So while it is important not to, it's important not to lower our guard. There is possible aerosol transmission, but it's also to have a healthy dose of realism about what is the level of this virus, right? So it's really low, the infective potential of this virus, how much can be transmitted. And even though dental aerosols might not be the source of dispersion of SARS-CoV-2, it is important to remember that these patients sit in your clinic and they talk to you and they sneeze and they cough. And so those are still aerosols that are produced. So we need to focus rather on methods of aerosol reduction during dental procedures to actual just aerosol barriers, right? In terms of other conversations. So maybe we still have to continue masking. So yeah, that's very unpopular.
Thank you, Purnima. Again, a very positive message. And Professor Chappell, what would you say?
Get vaccinated. It's just a no-brainer. And if you're not doing it for yourself, do it to save your grandma or somebody else's life. And don't be so selfish and thinking, I'm not going to get it done because I don't want it. Do it to save other people. I mean, I have to agree with Purnima. I think, and it's a personal theory, that the reason we were seeing such high seroprevalence in our pre-lockdown dental practitioners was because of conversations, which we always had without a mask with our patients. So I think she's right there. I think we will hopefully be able to get back to normal PP in the near future, but only if we get vaccinated. So please get vaccinated. Did I say get vaccinated?
Thank you, Professor Chappell. Here in Spain, we love to be vaccinated, but we don't have enough vaccines so far. So if you have some extra ones, please send them to Spain. But we are in the right way. Before we finish, I would like to remind everybody that you have already the link to fill the questionnaire for the post-meeting survey, and then also you can get the credits. But the link is in the chat tool, so you can just copy and it's already working. And but Dr. Bostansi, what would be your final message?
Thanks, David. And Ian, yes, we also would like to have the vaccine, but here we are considered not at risk group. Dentists have been great at protecting themselves. So keep protecting yourself. Indeed, that was the great message. So on the behalf of the Periodontal Research Group of the ADR, David and I would like to thank all speakers for their outstanding presentations. And thank you for updating us. And I think we have got the latest information. So that was really great. Also, Periodontal Research Group members, also the attendees who had the chance to watch you. And also we'd like to special thanks to go to Belen, who is our scientific group, network community liaison, and there's a new role in our group. And we'd like to thank her to spread the word to Globe. So we had more than 200 attendees today. So thank you, Belen. And my last word will be stay connected. Stay well, and I do hope to see many of you virtually again at the next IADR meeting in July. Take care.
So thank you, Nagi. Thank you, everybody. Special thanks to our 4 speakers today. I mean, Saso, Fale, Purnima, Ian. Thank you very much. It's been a pleasure. And yeah, see you soon, virtually or in person. See you very soon.